Hello, everyone. Welcome. Good morning, good afternoon, good evening, depending on where you're coming from. So I'm RJ Nagit. I'm the Knowledge Hub Facilitator of the Lessons Copper Project. And welcome to the first Lessons of the year. Actually, this is the fifth of the series in terms of the different lessons webinars that we've been organizing in the past year. And Lessons is actually a component of the Communities in Pandemic Preparedness and Response, or Copper Knowledge Hub, under the Copper Project, implemented by the Activist Coalition on TB Asia Pacific, or ACT-AP, hosted by APCASO, and the Africa Coalition on Tuberculosis, or ACT Africa, and the Regional Learning Hub of Anglophone Africa. Of course, this wouldn't be possible without the support of the Global Fund. So for today, we'll be tackling a very exciting topic focused on health equity in pandemic preparedness and response. So these are our webinar guidelines for the session. So of course, as you can see, it's being recorded. And we also ask our participants to change your Zoom name to the format. So you can use your name, and then you can also add your pronouns and then the organization that you're affiliated with. So for example, for me, my name is RJ Nagit, and then I can add he, him as my pronouns, and then Copper as my organization. As with any other webinars, no, if you're not speaking, we ask that you kindly put your microphone on mute, and as much as possible, if you can turn on your cameras, especially during the Q&A portion, that would be very much appreciated. And of course, you can use emojis or use the raise hands function at any point in the discussion. And you can also utilize the Q&A function or the chat function in our Zoom call, so that you can raise points as the speaker is actually doing the presentation. So this session will be conducted in English, French, and Bahasa. So if you're speaking Bahasa or French, you might want to log in to that channel. No? And of course, this is we hope to make this a safe space. So let's make sure that this is a productive discussion. So ask questions. Hopefully, we pick up something from the discussion today, and then later on, share your insights with your friends, your colleagues. So again, kindly put your speaker on mute if you're not speaking. So this is actually the instructions for the going to the translation channel. So you might at the bottom part of your Zoom, you will see a sign that looks like a globe. So you might want to click that and then select the language that you're comfortable with. So for this session, we have English, French, and Bahasa translation. So now, before we proceed with our discussions for tonight, I'd like to start with an icebreaker. So Mook, can you load our whiteboard? So from here, from your Zoom interface, you can directly interact with this whiteboard. So first, we can actually, I'd like to have a quick scan of the room where you're calling from. So you can use these post-it notes, so the pink ones here, to type in where you're calling from, or you can also chat your locations in the chat function if you can't access this whiteboard. So I think some of you are already introducing yourself in the chat. I see someone from Kenya. I see someone from Zambia, and also from Sierra Leone. So one of our previous speakers is also here. And thank you for attending. And we also have someone from Ghana who's also joining us tonight. All right. So I see there are few who are already starting to interact with this whiteboard. Oh, there's all, of course, we have someone from Cameroon who will be joining us later as one of the reactors. So are people having issues with controlling the whiteboard? You just need to hover over the screen, and you should be able to control the sticky notes here. Okay, so I see some people clicking. Oh, okay. Huh. Oh, that's why. Okay. Anyway, so if we're having issues with the whiteboard, I'll just read it from the chat. So I see some people coming in from Cameroon, from Nigeria, okay, and yeah, Gambia. We also have someone from Indonesia. We have someone from Thailand and Comores. Filipinas. Someone is from the Philippines and also from South Africa and Cambodia. Okay, so let's proceed with the next question. So, Mook, if you can also assist with enabling the whiteboard to so that our participants can utilize it, that would be also good. And since we're starting the year, I'd also like to ask everyone, what is your highlight? Because we're nearly done with the first month of the year. So anything exciting, anything new that you're starting this year? Okay, now I think everyone has access to it. So, all right. So I see a lot of names hovering over the whiteboard. So you can on the left hand of the screen, you can add post-it notes. You can create a text box, and hopefully in this whiteboard you can share what is your highlight for the first month of the year. It's okay if you are not comfortable sharing your name. So we just want to get a sense what people are actually up to in the first month of the year. Okay. Okay, so it's quite a busy whiteboard as I see it now. Uh, okay, someone had a picnic with their family. I think that's always a good way to start the year. Some of us are adjusting to the Trump administration. Okay. And some of us are, okay, writing. What is this a name? Lionel? Some of us are very busy. It's always a busy time at work, especially the first few months. Okay. And then some of us are preparing for all of the necessary reporting for copper. So I think, of course, we're not here to follow up on your deliverables, but it's good to hear that you're working on them. So if you're having difficulty with the whiteboard, you can always use the chat function. It's also fine. Okay, and then I also see here someone who wrote, I think, in French. So maybe Soma can help us translate. Okay. Okay, so okay, so someone also said Trump's decision plus. All right. So I think we can proceed to the next one. Okay, someone also mentioned preparation for sensitization to communities on copper CE. Okay, that's good. All right. We can move to the next question, Mook. And I think the next question is quite specific to our topic for this session. All right. So the next question is, what equity issue concerns you the most now? Because I know a lot of our participants here are working with a lot of community-based organizations, people's organizations, and marginalized groups. So I'm sure we've encountered several equity issues or inequity issues as we do our work. So again, you can also put it on the chat or type it here in our whiteboard. Okay, some of the answers are quite small, so I have to zoom in. Okay, I think someone is typing access. If you're having difficulties with the whiteboard, again, you can put it on the chat. Funding allocation. I think our speaker will talk a lot about funding, about as an equity issue. And then acceptability of services to specific key population. And then I think someone is saying here discrimination. Yeah, funding gap is a big concern. Limited resources. Yeah. Okay. So here someone said on chat, PPR idea is one of the best, but funding is a big concerns. It's a big concern. And then someone also mentioned equity when it comes to disability issues. Definitely, that's something that we need to um, address, right? Oops. Anything else? Sustainability and transitioning. Okay, that's interesting. And also someone mentioned current challenges in the global health landscape. And I think now it's a perfect time to talk about equity because of the developments that is currently happening at the global scale. Okay, I think we can proceed to the second to the last question. And I think the next question is specific to pandemic preparedness and response. So in that context, what are the possible equity issues that we might actually encounter? So I think we're having challenges in the whiteboard, but can you just type it on the chat, please? What do you think are the possible equity issues that we'll be encountering when we talk about equity in pandemic preparedness and response? Yeah. Okay. Am I audible? Okay, great. So human rights, yes, that's also one issue that we need to really emphasize. Okay, so now I think it's time that we proceed to the next part of the discussion. So thank you so much for sharing your insights. So again, I'd like to emphasize on what lessons is. So it's a series of webinars organized by ACT AP, and it's a continuing initiative which started during the Community Engagement and Leadership in Epidemic Governance and Response, or the CELG project initiative of the Global Fund, and now it's continuing under COPPER. So our objective is to equip participants on knowledge on pandemic preparedness and response through a series of webinars and inviting also a resource person and knowledge exchange, conducting knowledge exchange activities with our country implementers. So as of now, we've conducted 4 already. So this is the 5th lessons webinar. So all of the recordings can be accessed in the Copper Knowledge Hub website. So you can scan this QR code and also enter this link in your browser so that you can view all of the recordings as well as the summaries of the discussion. So you can also follow the Apcaso YouTube account, and then all of the presentations are also uploaded there. We also have some knowledge materials that we would like to share. So you can also access the community guide on MPOX. So this is a guide for civil society in terms of what they need to know about MPOX. So again, you can scan the QR code as well as the link. I think you can click it directly from the screen so that it takes you to the website. And then we also have a PPPR training module that you can also share to your other civil society organizations in your country. So we also offer a certificate of completion for the attendees of the webinar. So you just need to attend the webinar, participate in the discussion on the WhatsApp group. So later I'll be sharing with you how you can join the WhatsApp community group. And then you also need to accomplish the evaluation form at the end of the session. So now, before we proceed with our main resource person, I'd like to invite Jeff Acaba, APCASO Program Manager and ACT AP Coordinator, to give us a welcome message. Jeff?
Thank you, RJ, and thank you everyone for joining in this first lessons webinar of the year. But in total, this is our fifth lessons, which will focus on health equity. I just want this to be very quick, and I know that as we saw in the responses in the icebreaker, one of the really major things and challenge that has dawned upon us this year is the ceasing of operations due to the U.S. government's decisions to pull back all of its funding and stop all of its operations worldwide. And what does this mean in terms of global health, with the U.S. government being the largest donor and largest funder, not only for HIV, tuberculosis, malaria, but in the context of PPPR? What this means is it really changes the entire landscape in terms of how we address not only right to health issues, but really the social determinants of health that people experience. So what does this mean in terms of those who actually go to the clinics for their PrEP or ART? What does this mean to all the ongoing trials for malaria, for tuberculosis, and for other diseases as well in the context of PPPR? Everything that we've been preparing for since we started this project, even before under the CELG. But more especially in the context of health equity, what does this mean to those who are criminalized, those whose citizenship is not recognized, those whose personal identities, gender identities, and the very core of themselves is not even, if not recognized, even invalidated because of these decisions? And this is something that we should really be angry about. So when we talk of health equity, we're not only talking about social determinants, as I mentioned, stigma and discrimination, or economic inequities, social inequities, but really our rights as individuals and as people who should have the right to access the health services that we need, the health services that will keep us alive and survive in these trying times. So I hope that this lessons 5 will be a platform where we can discuss these issues. We will hear from two country partners under the Copper Project, but most importantly, our guest speaker for today will really talk about how Global Fund contextualizes health equity in its work and how will this impact our work. And perhaps later on in the Q&A, we'll also have some time to also at least try to use this as a collective emotional outburst of what's really happening in this moment of time. So thank you so much, and I hope you enjoy lessons 5 today. Thanks.
Thank you, Jeff. And I think one message that I got from Jeff is that health is inherently political, and inequities are political, and they do have direct impacts in our health system, in how we deliver our services, and also how we take care of ourselves. Because sometimes when people or the providers or the funders deny certain people of funding for certain services, then it creates a negative effect in not only individual but also at the systems level. So of course, we're very fortunate because we got a very good speaker for this session. So Emmy is a global health equity policy and program specialist with over 10 years of experience addressing the social determinants of health through research, policy, and programming. So Emmy has held various roles across the global health and development sectors, including serving as health inequities manager within the UK Department of Health and Social Care, where she led the design and formal integration of health equity principles into integrated care systems and community-based initiatives. Emmy has also served as the as consultant for various organizations such as the World Health Organization and UNICEF. So she holds an undergraduate degree in biomedical science from the University of Warwick, a master's degree in public health from Imperial College London, and is currently completing a PhD with a research focus on trauma and health equity at the University of Exeter. So we're very fortunate to have Emmy Michael to serve as our speaker for the topic health equity and pandemic preparedness and response. Round of applause for Emmy, and over to you.
Thank you, RJ, and very helpful to hear more about my background in these calls as always. It's a pleasure to be here. And equally, I can't help but empathize with some of the remarks that were made earlier today. I think it emphasizes the importance of health equity, recognizing that it is very political. But at the end of the day, there are communities at the end of the politics, and they should be at the heart of everything that we do. With that, I'm going to share my screen. As was mentioned, I will be presenting today on health equity and PPR, pandemic preparedness and responses. And I'll be speaking for about 15 minutes, and then hopefully we have some time for discussions and questions. I hope you can see my slides.
Yeah, I think that's great. Go ahead, Emmy.
Okay. Great. It's a pleasure to be here. My name is Emmy Michael. As was shared, I'm the Health Equity Lead within the Community Rights and Gender Department of the Global Fund. It's a pleasure to be here today, as we'll be discussing health equity and pandemic preparedness and responses and the importance of health equity in planning for health emergencies, but also in preparedness and responses. The ambition of my short presentation is to share a bit more about the challenges in accessibility when it comes to health emergencies, particularly around vaccines, diagnostics, and treatment. Discuss how financial and human resource constraints emerge in health emergencies and are emphasized during times of crisis. And finally, share a few pathways to ensure that PPR is equitable during health emergencies. With that, we'll share a few examples around the Global Fund's approach and commitment to health pandemic preparedness and response. So equity is critical in pandemic preparedness and response. Inequities, health emergencies don't actually cause inequities. They actually exacerbate the existing inequities that exist between populations and within populations, and disproportionately affecting vulnerable and marginalized populations. They undermine existing and effective pandemic responses by limiting access for these populations and reducing trust through various mechanisms that have social and cultural determinants, but also through the proliferation of misinformation. Some examples we saw is during the COVID pandemic, the distribution of the COVID vaccine was definitely disproportionate and inequitable. And by the end of 2021, a lot of high-income countries had administered doses to an average of about 67 per 100 people, while in low-income countries, the average was 4 doses per 100 people. Similarly, during the Ebola outbreak in West Africa, we saw that weak health infrastructure meant that vulnerable populations were at a disproportionate negative impact than others. So I heard actually, I think RJ mentioned the social determinants of health, and these come really to high profile and high importance during times of emergency and crisis. But to provide a bit more of context around social determinants of health in pandemic preparedness response, I wanted to go through a few key examples. There are others, but these are the core examples. First is economic status and poverty. Economic instability is exacerbated by health emergencies. We see issues with food insecurity, housing instability, and poor nutrition, and that further weakens resilience of populations of communities, particularly during health emergencies. Social and cultural factors come into high play when we think about stigma, discrimination that are driven by social cultural factors based on race, ethnicity, gender, disability. Often this affects health-seeking behaviors and access to care for these important and marginalized and vulnerable populations. Similarly, cultural practices and beliefs can influence how people respond to guidance, how they respond to the requirements within health interventions. Policy and governance, the inadequate policies around resource distribution, around health infrastructure, are exacerbated during health emergencies when there's a need to act quickly and equitably. Inadequate or poor policies mean that inequities can be exacerbated and hinder the effectiveness of PPR strategies. Education and health literacy at an individual, but also at a community and cultural level, has an influence on how people interpret health information, and often reduce individuals' ability to be empowered during health crises, and be able to navigate health systems by themselves. Access to health services, again, is also influenced by health emergencies, particularly during times of crisis where there are restrictions, for example, on movement we saw during the COVID pandemic. Any infrastructural barriers are exacerbated during these times, meaning that rural and underserved populations can't access the services that they need. But also beyond that, other populations that are vulnerable, migrant, internally and externally displaced populations, refugee populations, and people living with disabilities can also face barriers to accessing care. And finally, living and working conditions. We know that these are significantly impacted in the times of crisis because, first of all, people's incomes are disrupted, but also their working conditions can change and mean that they are more vulnerable or exposed to risk. So, a few overarching challenges when we're thinking about ensuring equity in pandemic preparedness and response. As you know, pandemic preparedness requires forward planning, and responses are imminent and people need to act quickly. So there are several barriers that can come into play when we're thinking about the need to move quickly. First and foremost, structural barriers. Weak health systems in many low-income countries act as a barrier to enforcing proper guidance and utilizing global policies. Financing-related barriers, often there is a need for short-term, quick financing, utilization of financing mechanisms, and where they don't exist, this often prevents the ability to respond. Often we say you need to prepare for a health emergency long before the health emergency emerges, and that isn't always the case, particularly when thinking about financially. Data gaps. Inequities can only be recognized if we have data to be able to track and understand them. And when these don't exist, it's hard to be able to prioritize responses and resources in those areas of inequity when you don't have the evidence to drive that decision making. Finally, mistrust. Often we find due to historical histories of medical abuse, but also inequities, coupled with particularly social cultural differences, health-seeking behavior can be disproportionate in different populations, and again present challenges in ensuring equity in the pandemic preparedness responses. When we think about specifically vaccines, diagnostics, and treatments, these same barriers emerge. Accessibility challenges from various structural barriers, transportation and infrastructure related barriers, geographical exclusion. We know that often very remote areas can be excluded from distribution and supply chain planning. Economic, a lot of countries, particularly low-income countries, rely on individual out-of-pocket spending to cover the cost of healthcare. And in the event of an emergency, this can prevent a barrier to accessing services and vaccines, diagnostics, and treatments. And as I mentioned, socially, when we think about stigma and discrimination. Some of the other key challenges are financing and human resource constraints. We know that many countries don't meet their allocated spending for health, and many low-income countries contribute far below the Abuja Declaration. And this gap comes into play in situations of emergency. Further high donor dependency for emergency responses is often seen. And as we can see, like in a day like today, dependency on donor funding can have its risks, which can be quite detrimental. Beyond that is also health workforce shortages. We hear about this more and more, but the World Health Organization estimates that that there's a global shortage of 10 million health workers by 2030, and these will primarily be in low middle income countries. There is a huge gap in the availability of health workers compared to the population that need them. And we see that during health emergencies, for example, during the COVID-19 pandemic, there was a big gap in the availability of healthcare workers to deliver the essential services needed during that time, especially when those services are disrupted for various reasons. We'll speak about solutions and recommendations slightly later, but this is where we see community services coming into play. Also thinking about the health workforce, unequal distribution of trained staff between urban and rural areas is a big challenge when we think about the equity in the pandemic preparedness and response environment, where there is a concentration of trained medical personnel within urban areas, big gaps in that distribution in rural areas. We find there are medical deserts, and that's defined ultimately as an environment where you have to travel a long or great distance to be able to seek and obtain the care that you need. And also burnout during health emergencies. I think this is a challenge faced both in high and low income countries where increased stress, increased pressure, longer working hours results in increased burnout and loss of retention of key health workforce. And finally, what I haven't included here is just limited training and retention for the health workforce. Particularly during times of crisis, we see that these fundamental aspects of workforce retention, like training, like progression, are lost, and therefore the sustainability of the health workforce is at risk. So ensuring equity in pandemic preparedness and response actually requires quite a comprehensive framework, and I'm speaking quite simplifying this quite extensively for the purpose of this discussion, just due to time. But one aspect of the pandemic equity and the pandemic preparedness response is around PHC and ensuring that primary healthcare systems are inclusive for underserved populations and think quite holistically, not just about service delivery in a primary care setting, but also how the social determinants of health come into play in primary health service delivery. The global recommendations highlight the role of PHC systems in empowering local communities and ensuring that economic inequities and other inequities don't influence access to primary health services. And this is really critical when we think about equity in the pandemic preparedness responses. The equity focus in PPR planning and national strategies is really critical here, thinking about the populations that are underserved and so on. Infrastructure as well. Healthcare facilities should include accessible and user-friendly design. In one of the earlier questions, I heard commentary around specific vulnerable populations, but also thinking really critically about how services will be user-friendly in the situations of crisis. For example, for youths, for example, for migrant and displaced populations, for example, for people living with disabilities. How should services be designed to ensure that during emergencies, they can still be utilized? And finally, community engagement, and definitely thinking about and incorporating community engagement mechanisms within PPR. We see that as a core component of all PPR assessment and planning tools. For example, the joint external evaluation, the state parties annual reporting, they all include guidance and mechanisms to ensure communities are engaged in PPR planning, but also response. So overall, recommendations and strategies can be split into short-term and long-term actions. First and foremost, in the short term, prioritizing high-risk groups in vaccine, diagnostic, and treatment rollouts, recognizing what vulnerability and risk means in the specific context that we're focusing on. what type of disease is causing the health emergency, and therefore who is at risk and who should be prioritized. We spoke a bit about financial constraints, and in resource limited settings, it's important to prioritize those most vulnerable. Leveraging existing community systems to deliver care, we saw in the COVID-19 response that this was critical to success. And finally, strengthening community systems and networks to engage in PPR, particularly in the planning stage before the health emergency onset. In the long term, embedding equity in all PPR frameworks, training healthcare workers on inclusive practices, particularly in times of emergency, and of course, domestic financing for resilience. I'm going to spend a few minutes just speaking about the Global Fund and PPR. First and foremost, just highlighting the fact that equity is front and center in the Global Fund strategy, maximizing equity, gender, and human rights. And in our context, similar to the context of the PPR, this means prioritizing those furthest left behind, including key, vulnerable, and marginalized groups, addressing social determinants of health, recognizing that these shape health outcomes, both within and across countries, and recognizing that closing gaps means shifting power to communities and building systems that respond to their realities. I wanted to highlight this because I think it's really critical to see that the considerations around health equity exist when a health emergency has arisen and before. And equally, contributing to pandemic preparedness and response is core to the Global Fund's objectives. It focuses on strengthening health systems to detect, prevent, and respond to pandemic threats, while safeguarding progress in the fight against HIV, TB, and malaria. Key aspects of the Global Fund's PPR response include surveillance and data systems, community system strengthening, integration with resilience health systems investments, and leveraging lessons from the COVID-19, building on our COVID-19 response mechanism initiatives. And to give a few case studies, the COVID-19 response mechanism by the Global Fund mobilized several billions to support countries in mitigating the impacts of COVID. It focused on health systems and pandemic preparedness priorities, such as lab systems, workforce training, medical oxygen supply, and also community engagement in PPR, as, for example, the COPPA initiative. Some highlights, it worked on enhanced laboratory diagnostic capacity, strengthened human resources for health, as we know that this often has a shortage, and also strengthened surveillance systems. And in my slides, a few other examples, once they're distributed across the globe, but a few highlighted here for diversity, include more recent health emergencies, Mpox, for example, community-driven approaches, for example, in Rwanda, investment in community health workers and digital surveillance tools to support the response to COVID-19. In Malawi, laboratory strengthening systems, and in Nigeria, the use of data for pandemic preparedness, and specifically within the digitization of data systems to support the country improve real-time reporting and decision-making during the pandemic. I'll end there, and I think I'm going to hand over to a few of the responders and RJ. Thank you so much.
Thank you, Emmy. And can we give her a round of applause? I think she delivered a very informative presentation. And right from the get-go, she said that inequities already exist and pandemics actually exacerbate them. And I think when she went to the different recommendations, it's always going back to the basics, like shifting to primary health care, strengthening infrastructure, making sure that leaders are on board, local leaders, and also making sure that there's space for community engagement. So I think it's always an issue of how do we actually become intentional in prioritizing those who are left behind, and also embedding equity considerations in the frameworks and our programming. And she also gave us a very quick run through of what Global Fund is doing. to expand that conversation on equity. And now it's shifting. Now we're seeing that it's not just TB, AIDS, and malaria that they're focusing on, but also including PPR as part of their efforts. So thank you, Emmy, for that short but informative discussion. So now I'll turn it over to our two speakers coming from our country implementers. So the first one is Chantorn Prong, who has been working in the public health and social development sector for 10 years. So currently he works as the manager, policy, advocacy, and resource mobilization head in Khmer HIV/AIDS NGO Alliance, or CANA. And second, we also have Bertrand Campower from the Four Impacts in Social Health Cameroon. So we'll give them 10 minutes each to present their reflections, and then we'll proceed with the Q&A. So I'll turn it over to Chantorn first. Go ahead, Chantorn.
Thank you so much, Archie, for introduction. Good evening, everyone from Cambodia. So, can you proceed my presentation? So, I think yes, my presentation just how to say respond to the presentation just made by Amy, and also what the country, especially Cambodia, has done under the Cooper CE project, as well as the previous projects that been how to say strengthening the roles of community, in the COVID pandemic, as well as in the pandemic, prevention and response and health equity. So my presentation will now how to say a bit longer. So I will try to summarize, how to say the key points. Next slide, please. I think like the recommendation shared by the IMI, there are how to say uh, many things. I mean, the gaps, faced by the committee and also CSO, to engage and to support, in the pandemic response, especially the COVID-19. So in this with the regards, CANA, receive support from the Global Fund to our original partner, APASO here, to do something around to understand the roles of community and CSO, in the pandemic, especially, during the COVID-19. So starting from that point, we conducted, a number of initiatives. The first one is around the stakeholder mapping, to understand, the well of engagement from of community and also CSO to engage in the COVID-19. So we during that period, we know the limitation, of community and CSO, especially under HIV, TB, and malaria program, for the response. Based on the result from the stakeholder mapping, only two CSO who were the how to say the grantee, but in our context it's called sub implementer of the C19OM or COVID-19 rapid response, funded by the Global Fund. So from that, from learning from that project, we learned that the risk compression and community engagement, was a main focus for the CSO and also community to get engaged. And then some intervention also we support, in addressing, some fake news or misunderstanding around vaccine. You may know Cambodia received the vaccine from China. So there were many, fake news, related to that vaccine. So that's why under the project we try to address, we try to support, or we try to educate our, community, especially, key population, under HIV, TB, as well as people living with disease, both HIV and TB, to understand to get, those vaccines. And then we how to say the result from stakeholder mapping. We also understand the investment regarding to the how to say the COVID-19, where the source of fund and also the amount of fund received by the community agencies also was very limited as well. So I think building on that, we also how to say conducted specific assessment on community engagement and leadership during the pandemic. So why we conducted this initiative were under the current project funded by the how to say the global fund. So you can see the engagement, the community engagement, were to identify and also to understand the inclusion of a last mile population. Uh, uh, like I share from the previous webinar, maybe last year webinar, in Cambodia, consider the last mile population, especially the internal migrant worker is the last mile population for TB program. And this, been recognized and also acknowledged by the national TB program and also key stakeholders. So right now we just concluded the community rights and gender assessment, and then the key population also, was included in the key and vulnerable population, size estimation. So the national TB program will prioritize, this particular group, to be included or addressed by the national TB, how to say, agenda. And then the result from the community engagement assessment, we also developed the engagement plan. It's called the engagement plan. This engagement plan was quite limited actually because it stated a lot of things that to ensure the roles of community and also the CSO, to fully engage in the response, especially during the pandemic. And then we know this the how to say the engagement plan was supposed to be operationalized under the Cooper. Otherwise, we discussed with the our partner Akaso Jeff is here and also Olive how to select some specific intervention to include in the Cooper CE. So right now some specific recommendation has been included in the Cooper CE project. So these are how to say the starting point from the community and also CSO, in responding to the pandemic, response, as well as to be well prepared for the upcoming emerging crisis. Next slide, please. So currently, like I said, some recommendation of specific intervention been integrated into the existing, Cooper CE. So this is very specific, unique, a project for Cambodia. So we started by, how to say, building the physical structure or spaces for community and CSO. So we started, to establish how to say a platform or mechanism in our term we call community and CSO led platform. So meaning that the member of this platform who are the sub implementer in our context, we don't say sub recipient, but we call the sub implementer under the Global Fund supported grant. From three diseases, HIV, TB, and malaria. And then the member not only just the SSI or SSRs, the member also from the community network of key population and people living with disease HIV, TB, and malaria, as well as we also expand, the engagement from other sector. It's called Cambodian Red Cross. So we have youth representative from the Cambodian Red Cross. So this particular, PPR platform play important role to support, to share, to do some advocacy around pandemic, preparedness, prevention and response in Cambodia. And you can see, some of some of our colleagues or PPR member are joining as well, and thank to those who are joining the session today. And then moving from the platform, we also how to say uh, we, we translated actually the regional, especially Jeff here, Akaso and the team produce uh, PPR training manual for specifically, Quincy and CSO to build the capacity around PPR. So we use that a manual to translate into local language, Khmer. It's called Khmer language, and then we just conducted, the training to how to say to roll out the training among our PPR platform. So around 20 participants, were attended the training, and then right now we are in the process to do step down training to the community health worker, in the provinces where the global fund are running right now. And then yes, and we also produce the PPR promotional material to support not only just the training, but to have specific material, on PPR to ensure that our community member, our community leader, are well aware of the PPR and how they can reach out, to their respective beneficiaries. And then another thing, and also very, very important, is about the advocacy. So under the Cooper CE project, we are doing some advocacy initiative. So you can see one is around the PPR advocacy roadmap. So we use the PPR platform to develop advocacy agenda or roadmap, to see how the roles of the committee and CSO, will contribute or support the national response to the pandemic. So this is what we are doing right now. And then the another one is around the community engagement. In our context, the engagement of community and CSO in the PBR is quite limited, and then it seems to be like far away between the community and also the government. So that's why we produce, specific or how to say ambitious, document to influence the government, to ensure that the community and also the CSO role, will be considered or included in the national response. Next slide, please. And then this is the last one, and also very, very important. The talking about the engagement of committee and CSO in the joint external evaluation and also the SPA cell, party, assessment report for the international health regulation. So we just, you can see the left-hand side is about the JE and also SPA sensitization. We just conducted the JE, Joint External Evaluation, and SPA workshop among committee and CSO. And then, the focal point is called IHR, International Health Regulation, focal point from the Ministry of Health, join and also share the country progress as well as the tool which the Ministry of Health, doing right now or has done. And then we learning from that workshop, all of our PPR platform and also key stakeholder, being aware of the IHO as well as the pandemic country plan, and also the draft, the process of the SPA. But just to let you know that the SPA seem to be, how to say, very confidentiality. The government, they said that they don't share this particular report with other, because it's about the government business between the government and also the WHO. And I was wondering as well, why they still keep it as confidentiality, and yeah, how it is possible if our community and also CSO, or especially the PBR platform, would be able to understand or to learn from those process, but they still say that how to say cannot share, with other. only the MOA and also the selected or line ministry as only, to be shared. And then you can see otherwise the impact or the result of the sensitization workshop. The government, the focal point of the international health relation, confirm, they will allow or they will, how to say, consider to have our pandemic PBR platform representative to join, in any how to say, spa, related event, for example, like consulting meeting, dissemination. So they will invite us as a committee and also CSO rep to join. So it's a good, a good start and also a good, how to say, agreement between our PBR platform and the how to say, the working group or the national program on pandemic. And the last one, we just also conducted the how to say, the exercise on engagement or level of engagement of the committee and also CSO in the JE and SPA process, and we found that no CSO, no committee, has been engaged in those process. So that's why, resulting from that, we produced the statement and also the guide. It's called community engagement guide for community and CSO. And this how to say, this document has been shared with APASO, our regional partner, and also with the Global Fund ODC as well. And then right now it finalized. We will share with our PPR platform member as well as the government counterpart, to understand, what we want as CSO and community, to be a part of the JE and also this part process. So I think in overall, the engagement, our engagement in the PBR as well as the JE and also the SPA, are quite limited. Otherwise, we will do more advocacy, to ensure our how to say, engagement is how to say, well represented, in those platforms, as well as to use some, evidence based. So we will do some study or case study or best practices as well, learning from the COVID, learning from the existing, program that we are doing right now, to share with the CDC of MOH and also the IHR, working group, how the roles of committee and also, CSO, will be able to contribute to support the national, PPR agenda. So I think that's all from my presentation. Happy to respond any question that may have. Thank Archie.
Thank you, Chantorn, for your presentation and also for sharing your initiatives in Cambodia. So I think from his presentation, we were able to see the importance of identifying the different stakeholders that we need to engage, the importance of creating platforms where people can work together and collaborate, and also the importance of capacity building so that civil society can participate better in the different processes for PPR. So now let's proceed to the next reactor. So I'll introduce you to Bertrand, who will share his insights coming from their organization. Over to you, Bertrand.
Yes. Hi to everyone. Thank you, AMC. Hi to everyone. Uh, the slide, please.
Yeah, one moment.
Yes. Yes. AG, thank you for the introduction. As you say, my name is Bertrand Campoy. I'm coming from Cameroon in Western Central Africa, in Central Africa. So happy to share some of our reflection, initially based on Amy presentation. And Amy presentation was really amazing, as she used very simple words so everybody can understand the link between equity and PPR. So in Cameroon, as I say, we focus on two specific points. Those points was raised by Amy, especially access to health services and policy and governance. So we implement a couple of activities to measure the and to identify the equity gaps and take appropriate action in the TB response in Cameroon. Our organization is more focused is working on primary healthcare, but with a strong focus on tuberculosis. As we know that tuberculosis will be the corner of the next pandemic will be around the airborne disease, and we should have a strong focus on TB response. Now, next, please. So today we are going to present two specific actions where we contribute to identify some equity gaps, make sure that we have evidence, and then we propose appropriate response. Quick introduction to say that for 25 years, our organization have been working to improve access to health service for the most vulnerable. As you know that when we talk about equity, we should have a specific focus on those who are the most marginalized of the society, those who are most vulnerable, is those people who have very limited access to healthcare services. So we use two specific intervention on this presentation. The first presentation was around community-led monitoring using One Impact for access to health services. And the next was the human rights scorecard to have some information around policy and governance around the TB response. So as I'm saying, marginalized population, they face systematic challenge in accessing essential health services, and there is also very inequality in the distribution of resources who exacerbate that disparity. In Cameroon, as we need to go with evidence, we use those tools, One Impact and Human Rights Scorecard, as the solution where we can identify the inequity, and correct those disparities. Next, please. So the first area we use for the past 3 years, we are using One Impact because we realized in 2020 we conduct a CAG assessment in Cameroon, and we have one of the key recommendations was to implement a community-led monitoring where we can really first identify what is the barrier vulnerable population are facing when they try to access healthcare services. So the last information we have we have 1 year information from last January 2024 until January 2025. So we identified that accessing healthcare services for the most vulnerable, there is two major gaps. During the review of the data from our CLM1 Impact, we realized that 71% of barrier reported was around accessibility, geographical and financial accessibility. And also 24 was related to availability of healthcare services. Those points was raised by Amy. And then we have evidence through our process with One Impact, we have evidence that there is still a lot of inequality. We still have a lot of barriers, but the challenge is that we should identify those barriers before addressing. And then the tool we use in Cameroon help us to have a systematic process through One Impact where we can identify those barriers. And we also have another area where we identify the limited access for the most key and vulnerable population. As you see on this graph, urban poor, because in big town there is a lot of slum, and then urban poor, 51%, they also face important barriers to access healthcare services. rural population and ethnic minority. Just to remind that this process is implemented in Cameroon in 25 health facilities. Those facilities are facility, as we can say, is primary healthcare facility, but with a focus on TB diagnostic and treatment center. Next. And the second step was to next. The second step is around policy and governance. And as I already said, that we are lucky that we have amazing tool provided by Stop TB Partnership, the Human Rights Scorecard. So with the Human Rights Scorecard, we try to identify it with partners from the NTP, from Ministry of Health, from those from the university, patient organization, TB survivor, community based organization, TB organization, health organization in general will come together with a lawyer consultant to have some kind of the review assessment of the level of commitment, engagement of the country around policy and governance on the TB response. So we have that evidence. We have that evidence that there is still more to do in terms of having a human rights TB focused based response in Cameroon. So you see, for example, when we complete this exercise, we still have issue around 45% around availability, accessibility, acceptability, and the quality of health services. And also we have lack of social protection. This is one of the key points in terms of vulnerability, lack of equity, focusing on those who are the most marginalized of our society. We have also discrimination and equal treatment, 50%. And one of the key points raised by Amy is the lack of participation of key and vulnerable population. So those two processes, we use those two processes to make some appropriate recommendation to target equity in the TB response in Cameroon. Next, please. So how can equity can be strengthened in the TB response using the two process we use, the CLM1 impact and the human rights scorecard. First point, through the data provided by the CLM1 impact, we have regular meeting with the NCP and Ministry of Health, the Department of Disease Control, to overcome those barriers, because we set up some kind of a core group, a core committee, where they analyze and provide solutions to the barrier identified through one impact. Through another project and the data we have, we can also provide direct support to the most vulnerable group. For example, there are transportation costs, because some people they have difficulties, especially the most vulnerable. They have difficulties to have transportation fee to go to their evaluation or to go to collect their treatment. So we provide direct support by providing transportation costs, and we also use some of our support to provide catastrophic costs. For example, because TB treatment is free here in Cameroon, but around the treatment, there are a lot of other exams need to be paid, and we provide direct support to those people. We also have high-level advocacy with Ministry of Health for the integration of catastrophic costs in the universal health coverage scheme. As you know, Cameroon is implementing universal health coverage since last year. And at the beginning, the catastrophic cost TB was not included, so we are conducting advocacy based on the evidence we have through the one impact. We also have, in terms of governance and policy, we have an advocacy roadmap for policy change based on the recommendation of the scorecard assessment, because the recommendation provide us 3 high-level recommendations to make sure that we can have a human rights-based response in Cameroon. Those recommendations is around participation, it's around specific law in terms of TB, and also more engagement of TB survivor in the whole process of the TB response. Also have a component on strengthening the national partnership for domestic financing and mobilization of TB patients for stigma reduction. Next and last. So our conclusion in terms of, next please. Our conclusion, if we need to promote equity in the PPR, this should be involved generating data and evidence with appropriate suitable tool, promoting inclusive policies who are adapted to local needs, and prioritize vulnerable population in national strategy. Next and last, so this picture was sent to me by my colleague, Leonela Kene, who gave me this picture to just highlight that equity is an issue where it's not equality, it's an issue where maybe we should focus on those who are the most vulnerable on the society. Thank you for that.
All right, very insightful comments there from Bertrand.
Yeah, okay.
And I think one thing I appreciated from his talk is that he talked about tools such as the one impact and the human rights scorecard as a tool to identify inequities. Of course, data is very important, especially if we want to manage something, right? So we have to at least have a baseline and then work from there. You know, hopefully, those in red in the human rights scorecard will turn yellow or even green in the next few years. And he also pointed us to some actions to strengthen equity, such as doing high-level meetings with the NOH, as well as providing direct support to marginalized groups, and also addressing the cultural factors by addressing stigma and discrimination. And he also ended with this present figure, which shows us the difference between equality and equity. So thank you, Bertrand, for that very insightful presentation. So now let's try to proceed already with our question and answer portion. So I invite Emmy, Bertrand, and Chantorn to open their camera and participate in our Q&A. So also, Rachel is also giving us a very good reminder here that equity is not the same as equality. So hopefully in our Q&A session later, you can also touch on that as well so that you can expound a bit more. So I see a lot of people raising their hands. So is Emmy, Bertrand, and Chantorn already here? Yeah?
Yes.
Okay. How about Emmy?
I'm here.
Okay, good. So I see a couple raising their hands. So let's start first with Lizzie Otaye, and then we'll go to
Great.
two Pauls
Thank
afterwards.
you. Yeah, thank you. So mine will be a little bit short. So first of all, I mean, all the speakers have talked about the importance of data. And of course, that informs the amount of financing that actually goes into PPR activities. But I need to ask Amy, in terms of data gaps, how does this affect fund allocation? We've seen a lot of communities saying they have enough data to support that they need more funding. But when it comes to the public space, they normally don't have this data. So how does that data actually inform the amount of money that goes towards PPR? Now that we're talking about equity, but also in terms of, I think, fluidity and flexibility of programs. I know with the Global Fund, they had the C19RM that really worked quite well when we had the COVID-19 pandemic. I just need to know how flexible is that sort of mechanism in being used for other threats like Marburg and Ebola and Mpox, etc. And also just a quick question to the presenter from Ghana. CSO mapping is very crucial, but I needed to know, how do you identify which CSO will be part of the platform that you have? How did you know who needs to be part of that and who doesn't qualify? Was there like some sort of a criteria that you used? Because we know very well community engagement is crucial, and I like the fact that you have done the CSO mapping, and then now the CSOs are also part of the platform itself. But I'm very curious on just knowing, how did you know who needs to be part of that platform? Thank you.
Thank you, Lizzie. I think two points there. So one is regarding the C19RM as well, and the second one is related to the selection of civil society. So probably we can start with Emmy first, and then proceed to Chanthorn.
Thank you, Lizzie. You asked really important questions that probably don't have the most easiest response. So I'll start with your first question around data and funding allocation. And I must start with a caveat that funding allocation is not really my jurisdiction. But I think you raise a big question around, how does data inform where resources are allocated and where they're not? And I would say the first thing is to differentiate between equity-focused data and general prevalence data. So resource allocation at an aggregate scale will consider the proportion of the response required based on the prevalence of disease and things like that. Equity-specific data, which is disaggregated based on various different dimensions like age, like gender, like your demographic, like your your location, that should be used to inform the allocation of the resources available. It should support prioritization. It should support a focus on the vulnerabilities that are most likely to be impacted by the emergency. So I think differentiating between the types of data is really important first and foremost. The second thing around those types of data that I spoke about, those disaggregation only often exist in an ideal world. Often we don't have those data. And then we need to think creatively about our data sources. Where can we leverage alternatives? What survey data do we have access to? What community level data do we have access to? And how can we use that to inform how resources are allocated appropriately based on need and based on who is vulnerable and who needs them the largest response? So I think that's a bit of a response I can give to the question around resource allocation. Your second question around the COVID-19 response mechanism, as you mentioned, it is very agile and very flexible, and it has been used to fund subsequent emergencies. As I gave an example, like Mpox and like Marburg and various other emergencies that have arisen following the pandemic. So the Global Fund's commitments don't exist just to COVID, but generally to health emergencies and pandemic preparedness and response. Over.
Thank you, Emmy. How about Chanthorn for the second question on identifying civil society?
Okay, thank you, actually. Thank you for the question. I think, the stakeholder mapping, I would say, was conducted, among, how to say, community network of people patient and people living with disease, and as well as the, all CSO, who were funded by the Global Fund. So meaning that all sub recipients, but in our context it's called sub implementers, and also sub implementer, to see how how to say, the intervention, or mitigation, strategy, to be put in place, to mitigate, the disruption, for into the ongoing program. So the result, were informed, has been informed actually, how to say, the level of engagement as well as a level of, investment, to those network and also CSO, regarding to the HIV TB program. Regarding the, how to say, the criteria of qualification, to select the PPR, led, how to say, PPR platform, which is the community and also CSO, led platform. Actually, Kana is the, how to say, in our country, Kana is the national NGO. Actually, we, how to say, we are the sub recipient for both HIV and also TB program, and then we are also members of the CCC or CCM. So it really, been, how to say, easy to coordinate among all CSO and also the community work, not only just working on the HIV, TB, and malaria, but other, health sector as well, to come together. Otherwise, the, how to say, the consensus or the agreement was made by the member itself, not about us. We have to say we mobilize, we invite them to you to join the meeting. Together around 30 how to say participants who come from different NGO and network, and then they discuss and all agree together. To because if like we ask a number of questions actually. If how to say the committee, also the CSO, we to have a specific platform really focus on pandemic PPR, and also we can learn, we can share, and we can also collective effort around advocacy, and then after that, they agree together, and then we also kind of under the CE project, we provide support, some support around technical assistance and resource to ensure that they have a regular, meeting, for example, like quarterly, and also something around capacity building, not only just the pandemic, but for example, like webinar, we invited to join, as well as the new, for example, like import, new, how to say, pandemic in Thailand, in Myanmar. We share. So that's why this the how to say the process and also the criteria. Like I said, the criteria is not set, but actually this come together. All of them are the guarantee as well as the invited. How to say audience. Like I said, we together with Jeff and also with Olive, the Global Fund, we don't really how to say limit or marginalize how to say limit the scope with our HIV/TB and program, but looking at the other sector or other actor as well. For example, like Cambodian Red Cross, we also invite the other sector to join, because the pandemic not only in our three disease, but like I said, other sector. So to come together and they agree together to join, and then we have we produce we have specific term of reference, role responsibility, and also how we the topic, the area of focus that we how to say we are running right now. So I think that's all from my response.
Thank you, Chantor. I see two Pauls raising their hands, so probably we'll just go by alphabetical order. So Paul Balogun, go ahead, please. Paul? Or maybe we can go to Paul Bangura first.
Because we are all PB.
Yeah.
Yeah. So thank you very much. Batran, my friend, I think, and I was looking at your data. When I see your data, I see our dashboard as well. Things are very common. The issue of accessibility is a very big problem. We have a very huge gap in the area of equity. I see you measure geographical factors, but also stigma is very huge in terms of accessibility. Then also, I don't know whether if you also identify discrimination based on economic status, to access services, because we have seen wherein patients are judged by what they wear, when they go to facilities to access services, so they are really discriminated. That's what is actually showing that, because there is no, they are not paying. We have not seen people paying attention to special population needs. That one is not prioritized. So it's like everybody access the facility, but special needs to say, okay, this one is disabled, this one is this one is that, so let's make a special need program for them. That is not, this is where we actually have a very huge gap in terms of equity. Those that actually have the resources will have quick access to facilities. We have seen that happening when we're analyzing our One Impact dashboard, you see. But those that are really economically down, sometimes they wait for a very long time to access services at facility level. This is a huge discrimination, you see, that's taking place. But also the area of the health providers, their attitude, the way they treat people, the way they judge people who are coming to the facilities and all of that. You know, if they know you are coming from X population group, they have the way they look at you. You feel stigmatized. You can know that they are actually pushing me. You know, and it's a huge problem. You know, so the issue of equity is something that we really need to, you know, we need available data so that that we can be able to close that gap. You know, it's a systemic problem that is actually occurring, and that I see similarities between Cameroon and our own, you know, one impact intervention here in Sierra Leone in terms of accessibility. Thank you very much. Yeah, but
Yeah, go ahead, Bertrand. Yeah, I think you're on mute. Yeah.
Yes, yes. No, my brother Paulo was just make a comment because all those who are using One Impact, they know how they are familiar with the data. They have a special attention because first, we believe that the power of the data should be the key point. And then once you have the power of the data, have the specific focus on the most vulnerable, because that is the way, the space where there are inequality, where there is no equity. And maybe we are lucky in Cameroon here because first, my organization, the mission of my organization is to make sure that everyone have access to equitable services. That's the mission of the organization. So once you have that on the mission of your organization, so all your programs, cross-cutting, should pay a specific and a special attention to equity. For example, once you have those data from One Impact, we have another project where we can provide direct support, for example, nutrition. For example, we cannot provide nutrition for someone who are, we provide nutrition, for example, for those who are the most vulnerable, for example. And through our data, as we have specific information of those who are most vulnerable, we use those data to discuss with the NTP that this is the situation. We are facing a process who is not equitable, especially for the most vulnerable. And sometimes we are very happy because the NTP like that data. The NTP is happy with the data because the NTP is part of our process. The NTP is part of our committee, our core group. And then when they have those data, they also contribute to change solution immediately, sometimes in health facility. So, as I can say, as Paul said, we all use One Impact, but once you have those data, you should pay special attention to analyze the data and have a specific focus on the most vulnerable and use the data for advocacy, because once you have data, clear data, many things can change. Thank you.
Yeah. Thank you, Bertrand. So basically, have good data and then action will follow, right? So I see Paul Balogun already here. He just recently opened his camera. So would you like to ask your question now? Paul, go ahead. Or if not, I'm also mindful of the time. So I just probably close this Q&A session with one question, and hopefully we can answer in only 2 to 3 sentences. All right. So because some of our participants mentioned that one of their highlights are the changes in terms of funding the development sector, especially health. In the past few weeks, we've seen a lot of development. So despite that, how can we continue advocating for equity? So in 2 to 3 sentences, I'll probably have each of you share your thoughts on this. Maybe we can start with Bertrand.
Very good point. As I already said, for advocacy, you need data. First point. But also for advocacy, as Shamron say, make sure that maybe civil society, they are part of all the PPR committee at country level. And as we are also part of the corporate project, and we made that assessment for the country profile, and at the end of the day, we realized that despite the regulation who allow each committee in Cameroon to have a civil society representative, but at the end of the day, nothing is happened. So have the information, know what is happening at country level. For example, look at the nice presentation of Cameroon. They are starting GEE and SPART. We are in the process of starting that. But actually, we are lucky that we have the consultant. We help us have information from what is happening from the government, uh, have the feedback from community in terms of what is the need of the community to be part of that process. And then that will facilitate the engagement. So first, have data, and then make sure that we are part of all the PPR committee at country level, because normally in any country in the world, when you see regulation documents, a term of reference of those committee, you should have a seat. Community should have a seat. But at the end of the day, we are not feeling that seat because we don't have information. And sometimes when we have information, we don't have the capacity. That's why the Copper project is a very nice project, because provide us information. Remember, for example, yesterday I went through the website of APCASO, and there is a lot of information. I discover huge amount of information. Should use those information, because when you have those information, you have the knowledge and you know how to be engaged. And we are not reading. That is the issue. Thank you.
Thank you, Bertrand. That's a little over 2, 3 sentences, but excellent points on data and, of course, community engagement. Very important as we push for equity. Chantorn, 2, 3 sentences maximum. Go ahead.
Not Cameroon. Okay. Um, Actually, yes. In Cambodia, we conducted like community rights and gender assessment in HIV, CRT assessment in TB program. We conducted, right now we are in the process of conducting TB sigma assessment, key and vulnerable population, site estimation. And then recently we just concluded how say exercise around on gender justice and sexual rights. Maybe it quite linked to how to say gender how to say sexual orientation, gender identity, gender expression, and characteristic. So I think use the finding, the result or the finding from this particular assessment or study, I think would be great to use as the intersectional response. For example, like a specific intervention that can respond to across 3 diseases. I think this is very very important, and it would be how to say worthwhile approach that the Cooper CE as well as the Global Fund is looking for as well. How the intervention or the initiative can respond not only single disease but cover all 3 diseases. I think this is very important. Using the existing recently report that we just concluded. I think that would be great. Thank you.
Thank you, Chantorn. Again, also beyond 2 to 3 sentences. But I think what he also mentions specifically is the need for us to emphasize cross-cutting issues that affect equity. And then lastly, Emmy, go ahead.
RJ, I think you've done a great job in getting the right people, because Chanton and Bertrand have already said exactly what I wanted to say. But just to emphasize, I think advocating for equity is really difficult, particularly in times of trouble. It requires persistence, it requires collaboration, as have been said. But just to end, I think 3 key activities and actions: centering communities in decision making, making sure that the people that are at the end of our responses and our planning are the ones that are using their voices to advocate for what they want. Because at the end of the day, a service can only be fitting if it's designed by the person that uses it. As was already said, secondly, using data and evidence to bolster our arguments. making sure that we're using the evidence that we have, being creative and innovative about sources, but using that data to really advocate, and as a powerful communication tool. Some people only hear in numbers. And then finally, I think building strategic alliances, collaborating with partners, because PPR is a collaborative effort. It's not done by one organization or one sector. It's done across sectors. And we tend to put our messages across to people that speak the same language as us. So we need to make sure that we're in the right spaces, give ourselves a seat at the table if one is not given to us, and make sure that we're in the right rooms, working with the right people.
Very well
Over.
said. I mean,
Thank you.
basically community, data, and strategic partnerships. And definitely we cannot work in silos. That's why the Copper Project is here, so that we can facilitate inter-organization, inter-regional collaboration, despite the very many challenges that we encounter in in the global health space. And of course, despite experiencing some setbacks now, we must continue the conversation. We must continue advocating for the sake of the communities that we work with. So I think it was a very fruitful presentation, as well as Q&A session with Emmy, Chantorn, and Bertrand. So let's give them a round of applause, and would also like to share this certificate of appreciation to our speakers. Okay, one moment. Of course, we'd like to thank Emmy for her presentation. Oops. Thank you, Emmy. As well as our two reactors for today, Bertrand Campor. Thank you, Bertrand. As well as Chantern Prong for your insights. So, of course, we'd like to take this opportunity also to take a photo with everyone. So we invite everyone who's joining us in the call to turn on their cameras if you're comfortable. And then Mook will also help us with the photo taking. All right, so I see our participants turning on their cameras.
Okay.
Nice to see everyone. Someone's in the beach, apparently.
All right, I'm gonna count on 3. Okay. 1, 2, 3. Everyone smile. Lovely. Thank you very much. Over to you, RJ.
All right. And thank you also to our former speakers, resource persons who are also present here. So I see Karine over in the call joining us. Thank you for joining us. And as promised, you can answer the evaluation form. You just need to scan this QR code. So if you want a copy of the speakers' presentations, we can send them over to you. We just need your email address in the evaluation form so that we can send them afterwards. And as always, you can follow Apcaso on social media so you can be updated on the next webinar. So you can follow Apcaso on Facebook as well as on Instagram. So it's _Apcaso on Instagram. And for those who haven't joined our WhatsApp group, you can scan this QR code and it will lead you directly to our community group where we can continue the conversation with our colleagues. So some of our resource persons also joined the WhatsApp community group, so you can ask them questions over there. So again, thank you for joining us. I'll just flash again the evaluation form. And thank you for attending tonight's or today's discussion. Bye, everyone. You can exit the call once you've filled out the evaluation form.
Thank you. Bye bye, everyone. Bye.
You.
Thank you.
Thank you. Bye-bye.
Thank you so much for that wonderful presentation.
Thank you so much. Have a wonderful day.
So we'll just keep the room open for a few more minutes, but afterwards we'll be closing the room. Thank you. Thank you also to Some and Wendy, who helped us in translating in Bahasa and French. I also see here Bernadette. Hello, Bernadette. How are you?
Hello, RJ. Hello, everyone. I'm fine, and you?
Good. Thank you for joining us.